Hi, you guys. Thanks for joining me for an Ask the Egg Whisperers fertility Q&A. I am doing this today with Dr. Dr Hassan. I'm super excited to have her on. She's from CCRM Dallas-Fort Worth, and you guys sent in a lot of questions, so we're going to get to as many as we can, and also hopefully get to your live chatted questions as well. So thank you for joining. Thank you for sending your questions in. Again, we'll try and get through all of them today, so hopefully you guys will learn a lot. And no matter where you are in the world, just know that you're not alone and everything is always going to be okay. Do a check-in, make sure you're doing okay. If not, reach out for help. Make sure you're finding a fertility posse or tribe to help you during this really hard time. So I'm sure Dr. Duret's going to join us here in a second. And as soon as she joins us, I'll start going through your questions together so that we can answer them together with you. So I'm still waiting for her to join me. I'm sure she'll be on in a second. So I hope you guys are having a nice Saturday. This last week I did a session on embryo diamonds. So those are the 8 things that everyone should know about their embryos. So we start off with the day your embryos were transferred. Here she goes. Hi, Dorette. Thank you for joining us today. Really appreciate your time.
Absolutely.
Okay, so for those who don't know who you are, I mean, we all know who you are, but you know what I mean. Just tell us about yourself, your practice, your books. I see the beautiful covers behind you. Do share with us.
Yes, so I'm Dr Hassan. I'm the medical director at CCRM Dallas-Fort Worth. And not only am I a physician in the fertility practice, I'm also, or have been a fertility patient. So my husband and I met much later in life, and we underwent 5 rounds of in vitro to ultimately have our son, who was born via surrogacy. So you mentioned my books. My books are in the background. The first one is Miracle Baby. Or I'll grab it. Miracle Baby, A Fertility Doctor's Fight for Motherhood. And it's my life story of what it's like to be both the fertility doctor and patient, and to see it from both sides of the exam table. It's also a book of perseverance, hope, and love. Anyone who just wants a feel-good book, this is a great book to read, because it really does tell you that anything is possible. We just have to be hopeful. And then the second book is the Fertility Manual, Reproductive Options for Your Family. This book, I wanted to write a simple, easy book that patients can read, and just breaks down the terminology in simple terms. How do you know you have infertility? When should you see the doctor? What types of treatments are out there, and which ones are good for you? And it's you mentioned this to me in the past. It's a great book if you're a patient and you want to explain to your mother-in-law or your friends. It's a good book to give to them so they have some understanding about what fertility is all about. And I'm so glad to be back on your show. I think we're going to have a great time.
We are. Let's get started. Okay, this question is from Sam. Hi, Dr. Aimee and Dr. Duret. Thank you for your time. My question is this: is there any way to improve DFI? For example, by using supplements or adding more antioxidants to my diet? What do you think?
So I'm assuming this person's talking about DNA fragmentation index with the sperm. So yes, diet, supplements are all incredibly helpful. A good lifestyle, clean diet, we see that makes a big difference in the sperm. So I would encourage them to do everything they can to improve the DFI.
So there's a second part to the question. They're a little bit worried because the DFI is actually 41. And Sam is saying, I want to repeat it, but my doctor is saying, no need to repeat it. Just 3 months of supplements. That's all you need. Don't retest. What would you do?
So I think both of them are correct. I think both the patient and the doctor are correct. So in theory, the sperm cycle is about 3 months. So in theory, if you have done a clean diet, vitamins, all of those things for about 3 months, in theory, the sperm should be good. It can't hurt to check it again, honestly. Right. It's a simple test, so it can't hurt to check it.
Yeah, I agree. Okay, this question is from MC. I have 2 questions for the live with Dr. Hassan. How do you become a reproductive endocrinologist? Which do you study and practice first, OBGYN or endocrinology?
Great question. I'm sure Dr. Aimee will agree with me. I feel like we have the best jobs possible. We get to help people create dreams and have those dreams come true and see their families begin or grow. And I think it's just amazing. So to become a fertility specialist, you do 4 years of college, then 4 years of medical school. And then after medical school, we did 4 years of an OBGYN residency. So we both have delivered lots of babies in the past, and we both have done lots of other gynecological procedures. And then once you're done with residency, you do 3 more years of what's called subspecialty training in reproductive endocrinology and infertility. And that's how you become a fertility specialist.
That's a whole lot of years to figure out an egg and sperm make baby. That's for sure.
We have to go through all of that just to know about the
Yep,
birds and the bees.
exactly, totally. So there's a second part to this question from MC. I've had 6 transfers of untested embryos. Only ones where I've had no implantation of any kind were the ones where I took, it looks like heparin and aspirin. Could these be impacting my implantation success is the first part of the second question.
So most likely no. These embryos, from what I gather, were not tested for PGTAs. At age 41, a large percentage of our embryos are going to be aneuploid, and that's most likely the reason that this person, the embryos did not take. We use heparin, Lovenox, blood thinners in general, for women with recurrent pregnancy loss, recurrent implantation failure, when we see certain markers that are abnormal. The person carries lupus anticoagulant or antiphospholipid antibody panel. Occasionally, I give it empirically where all the testing looks great. We've done everything possible. We keep putting in good euploid embryos into good uterus and not getting pregnant. So it usually has a beneficial effect, usually not a negative effect. So I suspect in this 41-year-old, it's probably aneuploidy.
Right. And then when do you time your start of the Lovenox, for example?
I time mine whenever they start the progesterone, so usually about 6 days before the transfer.
I'm pretty similar. I start 2 days before, but that's good to know. Okay, so this question is from Beth. I took 600 milligrams of Advil after injuring my foot. Will Advil delay ovulation? I'm on day 12 of my cycle. Thank you so much.
Oh, do not beat yourself up for taking some Advil because of your foot injury. So the reasoning behind that, Advil is an NSAID, and NSAIDs inhibit COX and prostaglandins, and those are necessary for a follicle to rupture and release the egg. If you happen to take 600 of Advil, I really doubt it's going to have a huge negative impact on your ovulation. So don't feel guilty about it. You really needed it for your foot pain. I wouldn't worry about it.
I agree. If you're trying to get a good night's sleep and you have foot pain, that's not going to be good for your fertility either. So you didn't do a bad thing. Okay. So this question is from Jessica. Hi, doctors. I'm 35 years old, and here are my stats. AMH is 4.7, FSH 7.7, LH 5.7. I've had 3 egg retrievals. In the first one, I started with birth control for 11 days, Follistim 9 days, Menopur, Ganirelix. I got 9 eggs, 8 were mature, 5 fertilized, 3 PGT normal. In the second cycle, slightly different protocol, 13 eggs, 11 mature, 1 normal. Third cycle, birth control for 6 days, did the first protocol with more Menopur and also got 1 normal, just like the second cycle. We had a failed FET last month, and this is what we're doing next. I have an ERA receptiva coming up with a 4th egg retrieval scheduled after. I seem to get worse results with each cycle, particularly rate of fertilization. My RE was very surprised with my results given my AMH. Is there anything else I should do? Would you recommend any changes? My RE discussed possibly all Menopur protocol, maybe cut out the birth control. What else should we do to increase my chance of success, especially with an FET?
So remind me again how old this person is?
35 years old.
Okay, so 35 with a good AMH. So I think this person just had a run of some bad luck where it seemed to her that it's getting progressively worse with each cycle. But I've seen others where it gets progressively better with each cycle as well, with each egg retrieval. She's 35. She has an excellent AMH. I think she's going to do very well with her fourth egg retrieval. And one thing, just to give her reassurance, is if you and I did the same protocol in the same patient month after month after month without changing anything in her protocol, we would get very different results with each month. And there's just a variability with our cycles, and that's all it is. So I would not I wouldn't lose hope in terms of seeing this with each cycle. I'm glad she's doing the ERA testing. She's failed one transfer, which I think was with a euploid embryo. So I think doing the ERA is great now. But I think her situation is quite hopeful still.
Yeah. Though I agree with probably maybe not using the birth control pills, but I wonder if it might be more helpful to do her fourth retrieval first and then do the ERA. You know what I mean? Rather than suppress the ovaries for so long with the ERA. What do you think?
I agree with you. I would do the fourth retrieval first before suppressing the ovaries.
Yeah, cool. Awesome. Okay. This question is from Kyle. I'm 40. I have 2 frozen embryos, blocked tubes, and have been told a number of times that my uterus is beautiful. Given nothing else is going on, what transfer protocol would you use?
I think she has a really good chance of doing well with the frozen embryo transfer. With her scenario, no previous uterine surgeries, no fibroids, any FET protocol would probably be fine for her. So REs use various versions of estrogens, oral, vaginal, patches. I think any of those versions, even a natural cycle, would work fine with someone where there's no significant uterine history.
Right. So what she's wondering also is how long can she wait to do another IVF, like another egg retrieval? Should she have her baby first, be 41, and do another cycle? Her AMH is 4.6. That's another question she has.
Okay, so she has an excellent AMH, which is fantastic. But what I would do if I were in her shoes is I would do another egg retrieval, bank more euploid embryos, and then do a transfer and have a baby. Because think about it, she's going to be pregnant for 9 months and then maybe have to breastfeed and a few more months before she actually gets back. It'll be about 1.5 years before she's back. And after 40, really every 3 months starts to make a big difference. So I would bank more embryos.
Yeah, I agree. Okay, this question is from Danielle. Thank you so much for answering our questions. Could you please tell me what supplements beside prenatal vitamins you recommend to your patients to take during the 2-week wait and during pregnancy?
I tell my patients prenatal vitamins, if you take 1 prenatal vitamin, that's all you need during the pregnancy and during the 2-week wait. Now, prior to conceiving, I have multiple supplements, just like you use the coenzyme Q, the DHEA, lots of vitamin C, vitamin E. But once they're pregnant, a prenatal vitamin should be more than ample.
Right, I agree. So, it's hard, especially when you're pregnant, to also add in like fish oil, vitamin D, because sometimes you're so nauseous you can barely keep down the prenatal. But sometimes I suggest that. And there was one study, someone else brought it to my attention about CoQ10 and possibly helping with miscarriage. So sometimes, depending on the patient, I'll have patients continue that in the first trimester, and sometimes even like inositol or avasitol if they have some glucose homeostasis issues or they can't tolerate metformin. But I agree with you. Okay, here's a great question from Bree. Bree is asking, hi, if my husband has a grade 2 varicocele, do you recommend surgery after IVF in my second trimester or before IVF? And if before IVF, how long should he wait after his surgery to do IVF?
Good question. So varicoceles, the mild, moderate, but it sounds like his one's moderate, many times they do not need surgery and can go straight into IVF ICSI. Occasionally, sometimes a urologist may give them medications like Clomid, letrozole, HCG to kind of boost the sperm quantity quality, but many times they do not need surgery. Now, the severe varicoceles, many urologists will probably consider doing a varicocelectomy in those situations. It takes a good 6 to 9 months to really start to see a difference. And one of the things they do, especially if that man's wife is advanced reproductive age, time is of the essence. Sometimes after they've done repaired the varicocele, they'll 3 months later, the urologist can start them on medications to try to boost the sperm count, just to catch up in terms of timing.
Right. I agree. And that's sometimes how, or when I use the DNA fragmentation test, kind of like a traffic light. So if you have a varicocele, especially if my patient is over, let's say 37, if the DFI is really good, then I'm like, let's just go for it. But if it is really, really bad, then sometimes it makes sense to take a pause and think through that. But I agree. Okay, so this is a question from Robin. Hi, Dr. Aimee and Dr. Nurhassan. I'm a longtime fan and so appreciate your passion to advocate and educate about reproductive health. My FSH is 7.4, AMH is 2.81, estrogen less than 20. I've been told those values look okay. However, my AFC is only 8. Is this normal for a 33-year-old? And the second part of this question is, how many eggs does it typically take to get a PGS normal embryo for someone who's 33?
So all great questions. So the antral follicle, by the way, she's a great age. Her AMH is excellent. The antral follicle count is subjective. Sometimes you can see with high resolution ultrasounds, you may be able to see more follicles than there with lower resolution ultrasounds. So it's a very subjective call. Antral follicle count, I say about 8 to 10 is about average. So I think 8 is fantastic. I would not beat myself up about the 8. I think her AMH is great. Her age is great. So I would not worry. Because she's less than 35, she has a great AMH. She may get a good euploid embryo in that first IVF cycle. So I think she has a lot working in her favor.
I agree. And the other thing is sometimes just repeating the AMH will give you a more accurate picture of what's going on, because there can be so much lab variation. You get this high AMH and then you see the lower egg count and you think that something's wrong, but sometimes it could just be that. The other thing, what was I going to say? Just this competition that's out there with social media, people posting how many eggs they're getting, and then they feel so bad if for some reason their egg count isn't similar to what they're reading online. But you and I both know so well that it's truly not about the quantity of eggs, especially for someone who's young. The quality should still be good. So there's lots to be hopeful for. Okay, so this question is from Mo. Mo asks us, doctors, I love the show. I'm a 33-year-old female and my partner and I have been diagnosed with unexplained. My AMH is 6.54, FSH 8, estradiol 21, and my partner's sperm all normal. We recently had our first IVF, which resulted in 19 eggs retrieved, of which 16 were mature, none fertilized. When we asked if rescue ICSI could be done, we were told that the eggs were not mature enough for ICSI. Could you explain why this may be the case? My doctor wants us to do another round with the medication protocol altered. However, I'm afraid the same thing might happen again. How can I find out if there's an egg quality issue? Would you recommend us do a sperm DNA fragmentation test? And what could cause totally failed fertilization? I know that was a lot of questions, so I can ask the first one first. Rescue ICSI, what do you think about that?
So good question. So I was just listening to the entire scenario. I just listening to the scenario. I think that this person had standard insemination with their IVF process. She listed incredibly good prognostic values. She was under 35, a great AMH, great FSH, 19 eggs retrieved, 16 mature. Now, it can't hurt, first of all, to get the sperm DNA fragmentation. The semen analysis is great. It can't hurt, just for knowledge, just to know if that's something she wants to know. It cannot hurt. In unexplained infertility, and I tell my patients this, that's a very difficult category because people like to know there's something wrong and we can fix it. And once it's fixed, they're going to have the baby. But about 20% of the patients I see have unexplained infertility. When they have unexplained infertility and are going to do IVF, in the past I've said do half ICSI, half standard. Now I just say do all ICSI. So about 10 to 20% of patients with unexplained infertility can have a problem with fertilization on a cellular level, meaning once you put the egg and sperm in a petri dish, they still don't know how to get together. And I've seen this happen before in my career where great eggs, great sperm, perfect cycle, young couple, and standard insemination should work. But about 10 to 20% of unexplained infertility patients can benefit from ICSI. Now, the reason her physician probably said they could not do emergency or second day ICSI is that the window that a sperm can fertilize the egg is only X number of hours. And so ideally, typically when we do an egg retrieval in the morning, they do ICSI in the afternoon. But if you wait until the very next morning, the eggs have gone past the stage where they would be receptive to the sperm. So second day ICSI or rescue ICSI is usually not beneficial in those cases. I would say do the cycle over and from the get-go plan to do ICSI from the very beginning, and she's going to do awesome.
I agree. I would say the exact same thing. I mirror that. Okay, so this is a question from Melissa. Hi, doctors. Looking for your opinion on starting IVF sooner than later. Tushy all checked. AMH was 1 in May, but then it was 0.24 in August. 4 failed IUIs, 5th done yesterday, and I'm only 32 years old. I started acupuncture 2 weeks ago, and the doctor told me I would be wasting my money if I do IVF now. And if I wait a couple months, this is what the acupuncturist told her, she can get my AMH level up for a better chance of successful IVF. My fertility doctor, however, thinks I should start my egg retrieval next cycle if IUI is unsuccessful. Also, my current insurance does not cover IVF, but if I switch from my husband's to my insurance with my job, I can have coverage in January. Do you think I have the option to wait? Do you think acupuncture can help? What do you recommend?
So January is just around the corner.
Exactly.
It's 3 months from now, and it sounds like your IVF is going to, or this patient's IVF is going to be covered. So I think waiting that 3 months would probably be okay. And I think she still has a very good prognosis. And this goes back to exactly what you mentioned earlier on. There's so many different labs that analyze AMH, and if you had your blood drawn today at 3 different labs who ran AMH in 3 different ways or 3 different assays, you may get completely different results. And so I wouldn't be too burdened with the discrepancy with the AMHs. You can always repeat it at a different lab. I don't know what her antral follicle count is or what her response is during these 5 IUI cycles, what her response to medications were like. All those things can really give us some idea as to her egg reserve. But I think she could potentially wait those 3 months.
Mm-hmm. I agree. I tell people your eggs don't decline overnight. They decline over time, especially when you're 32 years old. Yeah. It's different when you're 30, 37 or 41 or 42. Things change a little bit faster for some people, faster than I agree. Okay. So this question is from Tatiana. She says, hi doctors, thank you for taking the time. I would love to know how or what protocol would you give someone who has MTHFR 2 copies of C677T, and I'm thinking about asking you for supplement, diet, medication, or treatment recommendations. Thanks for all you do.
So great question. MTHFR is actually quite common. Many of us walking on the planet carry the MTHFR gene. And what I tell patients is just extra folic acid. So I make sure they have a prenatal vitamin with high dose folic acid. If not, I will prescribe extra folic acid, and that's usually enough. So the MTHFR, it's just a mutation in the gene that metabolizes folic acid. And so the person with this mutation do not metabolize folic acid as efficient as someone who did not have the mutation. And so all we do is we overload the system with more folic acid, and then we're usually okay.
I agree. I mean, sometimes I'll check a fasting homocysteine. I'm sure you'll do that too, just for additional reassurance. But there's so much online about it, and I think people sometimes think it causes a lot more problems than it really does, especially related to things like implantation and egg quality. But who knows, maybe for some people it can, so I'm never gonna like discredit or what they say. but I feel like there are so many other reasons for our problems, and MTHFR isn't always the culprit, but sometimes it's blamed too much. So Rachel is 43 years old and considering IVF again. It's been 3 years and I have not had success yet. I've heard about ovarian rejuvenation. What are your thoughts?
Okay, so ovarian rejuvenation is very, very new and still experimental, still done under IRB protocols. And essentially, many times they will draw blood from you, spin it down, and get cells that can be re-injected back into the ovaries. They sometimes will use certain other supplements that are proprietary that can be re-injected back into the ovaries. The word's not out, yes, as yet, if it's going to be beneficial or not. So it's hard to know if the ovarian rejuvenation is going to be beneficial. To be in this woman's shoes, though, anything that she feels that can help her, I think she should pursue it, as long as she understands that it's still experimental.
Right. I mean, I have never had a patient be successful with it. I mean, I think the stats are like 1 in 800 could benefit, and that's a whole lot of injections to possibly get such a low chance of pregnancy. But I hope one day, wouldn't that be awesome if there was something that we could do to help women regrow eggs? I mean, that would
That
just,
would be awesome. And I think in 20
oh,
years, we're going to be able to take one of her skin cells and make an egg out of it. But that
right.
technology's not here right now.
I know. I wish. So she has a follow-up question. She asks, is PGS testing is highly recommended, but what can one do if there's only one embryo that makes it to day 3? 2 doctors I've talked to so far felt it wasn't worth it, and based on my research, it made sense to me. What do you think?
So this really depends on the patient. So I have some patients, they need to know that it's a euploid. They need to know that it's a good embryo before they do the transfer. And when you're 43, a very large percentage of your embryos are going to be abnormal, probably about 80% plus. So doing that PGS testing prior to a transfer can be beneficial because you're not putting yourself through the emotions of getting your hopes high that, okay, this embryo may take and you may get pregnant. And so some people do need to know that information. Now I have other patients, though, that are incredibly hopeful and do not want to put the embryo through the trauma of the biopsy. It's only going to be one embryo. We might as well just put it back in the uterus and cross our fingers. So a lot of this is a personal decision. It really boils down to the person and what they want to do.
Right. With, I think it's also lab dependent and physician dependent. So if it were me and I had a 43-year-old who had one blast, I would still encourage her to test it because I don't want her to possibly go through a miscarriage. But other people don't, might have a different opinion. And of course, you're right. It's definitely a individual decision. Okay, so this question is from Pre. Looks like she had a laparoscopy and hysteroscopy after her last miscarriage. They excised stage 1 endometriosis and removed an endometrial polyp. When do you think I can transfer next? And there's more to it. Her last pregnancy implanted near the cornua at the right side of her endometrium.
I think she can do the transfer next month if she wanted to. It's stage 1 endometriosis. It was just a polyp. There was no scar tissue. There was nothing else. She could do a transfer next cycle.
Yeah, and she asked, do you think any of the above, like the stage 1 endo and the polyp, could have been factors that caused that embryo to implant in the right side, right corner of the uterus?
Stage 1 endo, probably not. The polyp would have to be really, really large to have done that. But I'm glad she had the laparoscopy, hysteroscopy, because anything she can do to improve the implantation and not having a miscarriage going forward will be very beneficial.
Yeah, I agree. Okay, so this question is from Rashida. Rashida is asking, what is the difference between gonal F and follistim?
Oh, great question. So gonal-F and follistim are recombinant or FSH hormones that are made in the lab. Menopur, on the other hand, is purified urinary FSH, and it has LH, which is another hormone. So both gonal-F and follistim are made in the lab. And they are a little bit different in terms of follistim is it mimics the beta chain, and gonal-F mimics the alpha chain. But to date, there are no studies, no objective studies that say one is better than the other. And so physicians use them interchangeably. Certain insurance carriers, if your insurance covers medications, certain insurance carriers may contract with one or the other. But right now, there's no objective data that states one is better than the other.
I agree. And sometimes I have patients who, let's say the insurance changes and they have some leftover follistim and then they still have to pay some high copay for the gonal. I've even interchanged them in the same cycle and don't see a difference. Okay, so this is our last emailed question, and now I'm going to go to the live chatted question after this one, okay? So this is from Kay. Kay is saying, I've been struggling to get my IVF specialist to facilitate the ERA test before my first ever embryo transfer. So the question is, we finally wrote her an email to express our feelings about this issue. Basically she's asking, like, how do we communicate to our doctor to say this is something that we want to do?
Yeah, so great question. Some patients may want to do the ERA testing before their embryo transfer, particularly if you only have one embryo. So the ERA testing, many times you don't really need to do it unless you failed a transfer. But I can see where this patient's coming from. I suspect she only has one embryo. I think she should chat with her doctor and see if this is something that they can agree on. Sometimes you may have to move on to another doctor. And the doctor also has the right to practice medicine the way he or she wants to do as well. And if they don't feel that that's an indicated test, that they are entitled to do that as well.
Right. Yeah. I mean, I would say probably 4 out of 5 fertility docs in our area here would do the ERA test. What is it like in your community?
I think most of us would do the ERA test. It's a benign procedure. It's simple. It's easy. There's very low risk to it. If someone only has one embryo and they want to do it, they're asking for it. It's an easy test.
Right. Right. So there's a second part of this question. We just started IVF round 3, and I requested, so the Kay requested to split embryos at day 4, freezing some and letting the other half go to day 5 or 6 to get some blasts to be PGS tested. The specialist overseeing our care thinks this will give us false hope and does not agree. I'm feeling that she may not have our best interests at heart. Any advice on whether you feel it might be a good idea to change specialists?
It just depends on what the relationship is between this patient and her specialist. If they think it's still working, then continue with it. If not, they may have to seek care somewhere else.
Right, I agree. But morula freezing, I don't freeze morulas. Do you guys freeze morulas?
We don't freeze
No,
freeze
no.
blast.
So yeah, so if anything, and we don't even do day 3. I mean, I can't even think of the last time that I did a day 3 freeze. Typically we grow out to day 5, 6. I think your program's probably pretty similar.
Yeah, we grow to day 5, 6. You and I have been around long enough to have seen day 3 freezes, to have done day 1 freezes, but really the standard right now, or most places will do just blast freezing. Yeah. So that's the most common one.
Perfect. Okay, awesome. So now we're going to get to our live chatted question.
Okay.
Here we go. How many cycles of Clomid or letrozole can one do in their lifetime?
So good question. There was a large study, this has been decades ago, that says you shouldn't do more than 12 Clomid cycles because maybe there's some increased risk of ovarian cancer. That was decades ago that this study came out. And we know things are very different now. This is what I tell patients. For most treatments, and specifically Clomid or letrozole, if you've done 3 cycles where everything worked well, you've produced a follicle, the sperm was good in terms of the IUI, about 80% of patients would have conceived by that 3rd cycle. So if you've done 3 cycles, you may want to consider moving on to something more aggressive in terms of treatment.
Yeah, I agree. I think you're at risk for going crazy if you take Clomid for 12 months. That probably would happen. Okay, so this is a great question about the frozen embryo transfer. Is the success rate higher for a natural or a medicated cycle?
I think both can work, natural or medicated cycle. Medicated cycles are a little bit easier because you can control when the progesterone starts and everything else. Natural cycles is not as easy to hit the right date, and can be a little bit frustrating as a patient too, to come in regularly for sonograms until you have a follicle. So I think both are successful. I've done both and have had success with both.
Yeah.
If you're someone with perfect regular 28-day cycles, a natural cycle would be very easy. Someone with irregular cycles, it may not be as easy, but I think both can be very successful.
Right. Do you tend to do ERA for patients who want to do a natural cycle, if let's say they just have one euploid embryo?
If they have one euploid embryo and they, it cannot hurt to do an ERA. If someone says request an ERA, I'll do it.
Yeah. Okay. So here's a great question. Hi, doctors. Thanks for the fantastic work you do. I had a failed transfer and I went back to the doctor to prep for another transfer, and the doctor saw 2 cysts and they gave me birth control. I don't see the follow-up of this question, but I think the answer is, or the question, I'll just add a question to this. Would the birth control pill hurt my transfer success?
It should not hurt. I'm assuming they had cysts in the ovaries. They should not hurt their transfer success. So the doctor's probably just putting them on birth control pills to suppress the cyst. Maybe the cysts are making hormones, and hormones can have a negative or positive effect on the uterus. So by suppressing the ovaries, keeping them quiet so they're not producing hormones, and then the doctor can give them a medicated cycle and then control how the endometrium grows. So I don't think the birth control pills will be a problem.
Perfect. So this is a question. Hi, doctors. Trace-free fluid on day 14, a thin lining, and a dominant follicle 19 millimeters. Is this a sign of ovulation?
So this person has a dominant follicle, a little bit of free fluid.
And I think the thin lining, she says thin lining around the dominant follicle. So I'm thinking maybe I'm just not, it's just maybe just like a translation thing. But basically it's trace-free fluid and a 19 millimeter follicle, a sign of ovulation.
So if someone has perfect 28-day cycles or 30-day cycles and they're in my office around day 12-ish, and I see something like that, I would certainly draw their blood and check their hormone levels, because the hormone levels is going to be confirmatory if that truly is the case. I suspect so, just based on what this person's saying, but it's hard to know without doing any type of blood work.
I agree. Test, don't guess. It is so easy. Just get some hormone levels cooking and get those levels back. Okay, so this is a question from Joyce Moon 66. Would the trigger shot like Lupron only affect embryo quality, and more specifically, the rate of chromosome abnormality?
No, so Lupron only trigger shots, we do it all the time in our donor cycles, and we have fabulous embryos. So the trigger shot should not affect the egg quality, or should not have any negative effect on the egg or the embryo at all. Now, people who do Lupron trigger shots, if you're a patient and not a donor, if you do Lupron triggers, typically you don't do a fresh transfer. And most places don't do fresh transfers anymore, because Lupron can have a negative effect on the endometrium, but it should not have a negative effect on the egg or the embryo.
Yeah, I agree. So this is a question. Someone's asking, Dr. Nur Hassan, you said after 40, every 3 months makes a difference. Can you talk about that a little bit more?
So yeah, for all of us, not knowing anything about your AMH, your antral follicle count, all of us, at age 35, approximately 35% of our eggs and embryos are aneuploid. At age 38, it's about 50%. At age 40, it's about 65%. And then it starts to decline very rapidly after that. So a few months does make a big difference in someone over 40 when it comes to their egg reserve.
Mm-hmm. Yeah, that's a great explanation. So someone's asking a question, let me go back to it, about a mature egg. And the question is, what are the general parameters of a mature egg? And I see that it's Kay asking that question. So Kay is the one that asked the question about the morula and splitting it in between 2 batches and freezing it. So the question is, what defines a mature egg? I think that's probably the best way to think about it as far as her question.
So at the egg retrieval, the embryologist, we remove the fluid from the follicles, and the embryologist looks at the fluid on the microscope, and they pull out the mature eggs. So mature eggs, typically the egg has, or the genetic material of the egg has split, and so you see the egg, and then you see the polar body, and that's how you know that it's a mature egg. We call it an M2 egg. Ones that are not mature are M1s. You give it a day or two, they might mature. Very immature eggs that you can get out of follicles at retrievals are called GVs, and those are essentially not good at all or can't be used at all. So the definition of the mature egg is based on the way it looks under the microscope.
Perfect. Good. Okay, this question's from Jessica. Hi, doctors. At my clinic, they do non-invasive PGS testing, meaning they don't analyze the part of the inside of the egg and just cells around. I've never heard of this. Is this less effective?
So this is a great new way to analyze embryos for their genetic material. Why biopsy the embryo when you can just, in theory, if the embryo is secreting in the fluid, you can probably just gather some of the fluid and analyze that for the genetic makeup. I don't think it's completely mainstream as yet, because otherwise we would all be doing it. And so most places, including us, are still doing the embryo biopsies or the PGTA to look for aneuploidy. But I think in about 10, 20 years, we could potentially just get the fluid that the embryo grows in and analyze that for genetic makeup.
That's exactly what I just told someone yesterday. I said probably in 10 years, that's where we'll be, but not now. I agree. Mm-hmm. Okay, so this is a question about ICSI. Is ICSI really required if you do PGS testing? Does it make PGS testing less accurate?
So a lot of it depends on the lab that's analyzing your PGS sample. So a lot of the labs do require ICSI because it makes their analysis easier. They don't get a lot of contaminant DNA. Some labs don't necessarily require ICSI. So I would say whatever that IVF lab uses as their standard, you may want to stick to that.
Yeah, I agree. You don't want to tell the surgeon doing pediatric surgery to change their tools halfway through something that's so important. Okay, we have a whole bunch of questions. I'm going to try and get through as many as possible. Someone is asking, I'm 11 weeks pregnant and the baby's heart rate is 180. Is there something I can do to lower the heart rate?
I think you're probably okay with 180. You'll see as you progress throughout the pregnancy that the heart rate will go down a little bit more in that nice 120 to 160 zone. But I wouldn't worry, honestly, about the 180.
I agree. After successful implantation, when are over 24-hour tender sore abdominal area worrisome?
So I'm assuming this is after an FET. Usually you can take some Tylenol for that, but most of the times I wouldn't worry honestly about it. Embryo transfers are usually very benign procedures with very low risks to them, and there may be a little bit of tummy pain, but most people do very well with an embryo transfer.
Great. This question's from Stella. I'm 33. I've had 2 failed IUIs so far. I have hypothyroidism and I'm TPO positive. How does this affect my fertility?
So as long as the thyroid is now being corrected with Synthroid or some type of thyroid supplements, I think once you've corrected for the thyroid, then we can work on the fertility.
Okay. Someone's asking, what supplements should I continue prior to my FET? I'm currently on CoQ10 fish oil, DHEA, NEC, NAD, prenatals, and melatonin.
Okay. I have patients on lots of supplements. I usually say once they start the medications or the prep medications for the FET cycle, I usually pull them off of everything and just say stay on your prenatal vitamin is usually enough.
Yeah, I do the same. Okay, I had a DNC after a miscarriage at 14 weeks. I have 3 embryos left. Will the next transferred embryo have a lower chance to implant due to the DNC?
So this is a tough situation. I mean, to make it to 14 weeks and lose the pregnancy, it's really, really tough. but the DNC should not have a negative effect on your next embryo transfer.
Right. And I'm sure you're just like me. You would do a saline sauna or a hysteroscopy beforehand to make
We
sure
would
that everything
reevaluate. Yeah.
is perfect. Okay. So this is another question. How often should I retest FSH? Every 3 months? Every 6 months?
I usually have updated labs every 6 months. It's usually when I update labs. So every 6 months would be fine.
Yeah, that's my similar style. Okay. I'm age 29, low AMH, and no other issues. We had a PGS transferred embryo that stopped growing at 6 weeks and 2 days, and we have one embryo left. What would you recommend prior to transferring?
So a good evaluation of the uterus, so a hysteroscopy would be essential at this time. And it could just be bad luck. Even with having a great uterus and a good embryo, there's still only 60 to 80% chance of really it working. So there is a 20 to 40% chance of it not working. It may just be bad luck.
So once again, I'm 29, very low AMH, and we had 6 embryos on day 3, then 2 left on day 5. Is this a typical drop-off, or should we be investigating for other issues?
So 6 embryos on day 3 and 2 made it to last. That's fine. That's pretty normal. Yeah.
Can you please explain what is a natural cycle? And I think what she's asking is a natural cycle FET, because that's what we've been talking about today.
Yeah, so everyone does natural cycle FETs a little bit differently. The way I do it, so it has to be someone with regular cycles for me to do it. Sometimes I can stimulate it in various other fashions. But what I do is I have them come in for a baseline ultrasound and blood work on days 2, 3, or 4, make sure that they are at the resting or baseline stage. And I have them come back in for an ultrasound somewhere between days 10 through 12. Once they have a dominant follicle, roughly 18 millimeters or so. I trigger the ovulation with Pregnal, Novril, HCG, and then I start progesterone a couple days later, and then I time the transfer. So that's typically how I do mine.
So with someone who has a low AMH, would you rather use a mini stim protocol or a standard stim protocol?
Everyone responds very differently to different treatments. I don't have a set for low AMHs, this is what I do, or for this type of person, this is what I do, because I've seen such variable responses. I have various protocols that I use for my low responders, but they may respond well to this one and not to the other. But someone with the exact same prognosis, exact same numbers, may do the opposite. So I don't have a specific one for the diminished ovarian reserve.
Right. I mean, sometimes you can have someone with an AFC of 15 and they do better on a mini protocol. I'm just like, okay. So why are prednisone and Lovenox considered controversial when it comes to IVF?
Controversial in what sense?
I mean, I think for a lot of patients, they're told no when it comes to thinking outside of the box for certain treatments, probably. You know what I mean? So, like,
right.
Sometimes empirically you can use things, and then people are told it's controversial. And I think it's probably because there's no, if you don't have any test to support using it, that's probably the reason why some people call it controversial.
Yeah. It's not standard to use them right off the bat. Just like you said, empiric in someone who's maybe failed a few cycles, but we don't have any hard data that says you have to use them or that they are really beneficial.
Right. Okay, so here's another question. With someone with DOR, AMH is 0.27. Do you recommend any type of priming or birth control pills? And typically, do you do a mini stim protocol? I just had poor response, but antagonist protocol. 3 years ago, though, the protocol worked and I had a pregnancy that successfully delivered.
Right. So everyone's so different. So if the protocol worked 3 years ago, you can try using it again, but really 3 years have gone by and your eggs response may be different now than they were in the past. And this goes back to the last question. Various protocols work differently for different people. And so they may respond well to the mini stim this month, but next month they may not. So you really just got to try everything and see which one works best for you.
Right. I wish we had some sort of genetic or DNA panel or something
So
that will
no,
tell you
if
the
you
best
present
thing.
with this, yeah, if you present with
Yeah,
this is what works well for you, but we don't as yet.
we don't. Okay. So this is a great question. Can genetic testing hurt implantation rates?
Genetic testing of the embryos, I'm assuming PGT
Yeah.
is what you're asking.
Yeah.
It should not. So there's always some inherent risk of injury to the embryo when you're going to biopsy the embryo. But in really skilled embryology hands, you're looking at incredibly low chance of that happening. And so, in theory, no, PGTA should not should not have a negative effect on your embryos.
Okay. Let's see here. I'm 41 years old and we had 2 failed IVF cycles. This last one, we made it to day 5 with 3 morulas. Thoughts on implantation? What would you do in that scenario?
So this again boils down to that person and their doctor and what they're comfortable with. Some people prefer to do the PGTA testing and make sure it's a euploid embryo first, and others are, we've tried numerous cycles, just put it back fresh and see what happens. And this is a personal decision.
Right, I agree. This question is about a heartbeat that starts off low in pregnancy and then miscarries. The embryo was euploid. What are other common reasons for miscarrying in a case like this?
So when a euploid embryo in a good uterus doesn't work, you have to look at the embryo. It being euploid is good, but sometimes the cellular makeup of the embryo may not be as good as we think. We refer to that sometimes as the grade, but it's more than just the grade. It's the integrity of the cells, the ability of that embryo to survive, even if though it's euploid, and that can result in a miscarriage. I hope this person has more euploid embryos, and I would encourage them to try again.
Yeah. Someone's asking, we already answered it. Can an ERA be done in a natural cycle? And we already said, yes, you can do that. So this is another scenario. The day of the embryo transfer, I experienced an allergic reaction, swelling in my eyes and wheezing. Could this reaction be my immune system attacking my embryo?
It's hard to say if that would have caused the allergic reaction in the eyes. Hopefully they just took some type of antihistamine, and hopefully that helps. It's hard to say what that came from or what the reason for it was.
Yeah, I agree. I mean, it could be from one of the, sometimes, I mean, I give patients steroids and antibiotics before their transfer, and very rarely, but I do see allergic reactions to those things. Okay. My husband has it looks like maybe poor sperm binding, but excellent DNA fragmentation. Does that make sense is the question. Oh yeah, very low sperm binding, but excellent DNA frag.
I think it's still very good sperm that can be used for ICSI. So I would encourage them to continue their IVF ICSI process.
I agree. If it's 10% binding, at least you have binding. So that's a good sign. Let's see here. I had an IUI 8 days ago with a trigger shot. There are no traces of HCG. Could I still be pregnant?
She had an IUI 4 days ago with
8 days ago. 8 days ago.
Mm-hmm.
So I imagine the trigger shot was like 10 days ago, and it sounds like she's testing super early and often.
Okay. So I would just wait until about 2 weeks after the IUI for to do the pregnancy test. It's hard to know exactly when the HCG in the trigger shot declines and when the pregnancy begins. I would just wait until 2 weeks after the IUI and test at that point.
Yeah, I agree. We did it. We got through all the questions, Dorette.
Oh, that's fantastic.
Oh no, almost. There's one last question. Do you have time for just one more?
Yeah.
Okay, cool.
Absolutely.
Okay. I have autoimmune diseases, Hashimoto's, Raynaud's, Sjogren, I can never say that, Sjogren's, and let's see here. Let me go back. With only 2 untested embryos, would you recommend an autoimmune protocol like steroids, IVIG, interlipids, etc.?
I'm assuming this person's on treatment for all those autoimmune disorders. And both you and we use some form of steroids around the time of the transfer. That would be enough for me, assuming all the other autoimmune diseases were well controlled, and my steroid protocol would be enough for a typical FET.
I agree. Okay, let's see. Okay, 2 more questions. I lied. And then we're done, you guys. Last 2. My follicle count is 20. I'm 29 years old, and we're starting IVF, and I keep reading very mixed results on whether those are two good numbers.
I think that's fantastic numbers.
I agree.
I think you have a great prognosis. Go for it.
I agree. Can endometrial hyperplasia cause your embryos not to implant or cause infertility?
It should not cause your embryos not to implant. So first of all, if you have endometrial hyperplasia, you probably need to have that taken care of first. So typically there's 4 stages. There's simple and complex, and then there's with atypia and with both of those. So there's about 4 versions of endometrial hyperplasia. Typically, and you would have a GYN oncologist probably be involved in this process before even getting to transfer process. So most of the times you can do 3 months of high dose progesterone and then rebiopsy. A DNC is typically what they'll do. And if that specimen no longer show endometrial hyperplasia, then you're fine to move on to the next step. But you may want to have a GYN oncologist involved in this because you shouldn't have endometrial hyperplasia moving forward into a transfer.
Yeah, I agree. Okay, last question. This is a great one to end with. I'm just about to start my IVF cycle. What are your tips to do or not do? What are the do's and don'ts?
I think enjoy your IVF cycle. It's going to be fun. It's going to be great. And be hopeful, stay positive, and you're going to do awesome.
Yeah, I agree. I think just trusting your team and obviously understanding what's going on with you, your diagnosis, and making sure that you're not feeling overwhelmed. And if you are, make sure to check in with somebody and let them know. Okay, Dorette, well, thank you for your time on this Saturday. Thank you, everyone, for your questions. And then I hope you'll come join us again. Will you do that in a month or 2?
Absolutely.
Okay,
This is so much
awesome.
fun. All right, bye, y'all.
Love having you on. Bye, y'all.
Bye.
Bye.
Bye.